Hello everybody, I am Ahmed El-Shafi and I'd like to introduce this case of a dislocated IOL. As you can see here, the IOL is dislocated inferiorly and free mobile in the lower part of the pupillary axis. You can see the edges of the IOL. I'm doing such cases always with three-part system with a parasplantar vitrectomy. Some surgeons would do it with anterior vitrectomy through the paracentesis. The cause why I do it with three-part systems that in such cases, especially in high myopic eyes, you can manage any complication that could happen, especially if the IOL is dropped posteriorly, if the new IOL in this case will be iris fixation dropped on the macula, if by maneuvering the lens outside the eye, especially will make a very big opening in the sclera here. If any choroidal effusion or choroidal bleeding happened, it will be very hard to get with infusion in the eye. So you can manage any complication as fast as possible. And in every time before extraction of the IOL, I go with the cutter and I'm doing anterior vitrectomy here to be sure that no vitreous will come with the IOL outside the eye. And in such cases, when the vitreous comes, it will bring the iris with it, and it will be a little bit hard to extract and cut all the vitreous. After that, doing the periotomy and measuring a 6 millimeter. This is the measurement of the Artisan IOL. It's very important when you do the tunnel here, you should be superficial as much as possible to avoid any iris prolapse. Take your time in doing this tunnel. Some surgeons will hook the rectus superior and the eye will look downwards to make it much easier. Try to get one plane and to be superficial as possible. And when you do this tunnel, you should go a little bit to left and a little bit to right to make it in a pyramid way. So the IOL, so the opening in the inside of the eye is bigger than outside the eye. Now connection the infusion and be sure that it's running inside the vitreous cavity, not behind the choroid or behind the retina. Opening the anterior chamber. And here putting some little bit viscoelasticum. I am doing my paracentesis a little bit posterior here to be in the same level of the iris, and going with any instrument and pulling the IOL in the anterior chamber, and after that I do my vitrectomy. Take your time and be cautious, not cutting the iris. It happens and it's not rare. After injecting the visco, I noticed that the all visco comes again from the eye, and it's due to the high pressure in the vitreous cavity from behind. I'm going with a cutter and pressure the eye with my finger to aspirate a little bit of the fluids behind the iris to make it again deep anterior chamber. Grasping the IOL with this special Neuhan forceps, and it comes without any problems from the eye. And again doing this vitrectomy. I didn't done here a complete vitrectomy because the eye is vitrectomized before and the patient has undergone many retinal surgeries. Filling the eye again with PVD, washing the IOL. It's very important to notice here that if you will implant this iris fixation IOLs behind the iris, so the curvature must be parallel to the macula, and if in front of the iris, the curvature must be parallel to the cornea. Take your time here. I am measuring where the inclination points will be on the iris, putting one edge. It's very important to not push very hard A little bit inclination is enough, and the other side is good inclinated. It's maybe tricky, it's maybe take a lot of time, it's sometimes comes not from the first time. So take your time in this step. Take your time in inclinating the IOL. It's very important. If you did it badly or with much inclination, it will be hard to remove this IOLs from the eye. And now closing the tunnel with absorbable sutures. I would like to use these sutures because you don't need to remove it in the future. And the most important step in such surgeries is the tunnel. If the tunnel is bad, you will be struggling during the surgeries with iris prolapse and during closing the tunnel. And if it was good, you will only need one or two sutures to close the tunnel. I would like to recommend you in every parasplanavitrectomy to inject air at the end of the surgery to be sure that all the sclerotomies are tight. In this case, I was sure that there is no fluids or water are coming from my sclerotomy. But I would like to advise you to use air always in at the end of any plasma vitrectomy. And now making the second paracentesis to aspirate the visco from the anterior chamber and the little bit blood and cleaning the anterior surface of the IOL from the pigments. And now closing the paracentesis, you will notice that the anterior chamber will be shallow again. And after closing the second paracentesis, the anterior chamber will still deep. Thank you for watching.